fractures. Going into the epidemiology, they occur about 2 to 3% after 15 years and 8 to 20% with revision. What needs to be realized is that there is a high refracture loosening and failure rate, almost to the tune of 10 to 20% after treating these fractures. So I'm sure all of you are familiar with this Vancouver classification, which has 3 types, the A, B, and C. A involves the trochanteric area, AG being the greater trochanter, AL being the lesser trochanter. It's the type B which is the commonest, and if you look at this picture, then B1 is where the stem of the implant is intact, it is strongly holding, and there is a peri-implant fracture. B2 is when the stem is loose, but the bone stock is good. B3 is when the stem is loose as well as the bone is poor. And type C is when it is away from the implant or the prosthesis. So this is a very simple classification, Vancouver classification. And now, recently, Duncan and Michael Schutz proposed this universal classification system of periprosthetic fractures, where the joints are labeled from 1 to 6. The bones are labeled as per the AO classification. So you have 1 for the humerus, 2 for radius ulna, etc. And types A to E as per the Vancouver classification. So this is a comprehensive classification which is more useful and which is more unified. As per that, if you look at the periprosthetic hip fractures, then 4-3A will become what is type A in the Vancouver classification. 4-3B1 is where the stem is intact, holding well, and there is a periprosthetic fracture. B2 is prosthesis loose with good bone, and 4-3B3 is where the prosthesis is poor, loose and the bone is poor. Then they have 3 more variants. 4-3C is distal to the prosthesis. 3D is intercalary, when you have hip and knee both replaced, closer to the hip, and E being closer to the knee. So this is what is the universal classification. As far as management goes, there is a consensus that there's no point in keeping the patient in bed. There's no role of any conservative management, unless, of course, the patient is grossly unfit, because he can be due to many comorbidities. And therefore, the operative principles of treatment are or can be quickly summarized into spamming it. So SPAM stands for stabilize the fracture using a long plate, preserve the hip function, achieve bony union, and maintain component stability. So if the stem is loose, change the stem, use it like an intramedullary nail. Also augment it with extramedullary fixation, using usually relative stability principles. If the stem is stable, then your job is slightly simpler. You rely mainly on extramedullary fixation with relative stability. So when you're trying to fix these extramedullary, and that's the topic, my topic today, that's B1 type fractures, then you need to use longer implants spanning almost the whole bone, using principles of relative stability, and you need to fix around the stem using whatever contraptions you have. So it may be a locking attachment plate, you may have to use cerclage wires, the periprosthetic screws, which are flat screws, and unicortical screws, which essentially should not touch the prosthesis, because otherwise you would be losing the hold, and wires or cables. So do not attempt for rigid fixation, because this usually fails. Rigid in the sense, don't attempt absolute stability unless you have a very clear-cut oblique kind of a fracture well below the prosthesis, but usually this is not the case. You have a plethora of special implants available now, especially the periprosthetic plates, quite costly, most of them, but then very useful in certain situations. You may have to remold or, alter them, even though they are pre-contoured plates, to suit to your geometry and the augmentation methods that you are using. So let's go to B1, wherein the stem is stable. An example, 91-year-old patient. And this is the principles being keep the patient alive, 91-year-old, and get him out of the bed as soon as possible. So this is a trochanteric peri-implant plate, periprosthetic plate, with a strut fibular graft, medial or anterior. and fixed with cables in the proximal half and screws in the distal, something like this. Another example, use of circlage wires. Now, because of the prosthesis, most often you cannot put locking screws in the proximal and fragment, and therefore circlage wires or cables need to be used. And they are as good as screw fixation modalities. They can be done with minimal soft tissue damage. Nowadays, if you're attempting a MIPO, you have a percutaneous circlage wire passer and cable passer, and therefore can be done without damaging the soft tissues. What is more important is to clearly differentiate between B1 and B2, meaning if the stem is stable or not. Because if you are in doubt about the stability of the stem, then it is better to replace the stem or revise the stem and fix the fracture. For this, there is a good paper by Lindhall which says that most of the failures are because of errors in judgment, whether it's B1 or B2. And for this, an intraoperative stability test has been recommended by FOSIC, wherein you actually physically test the stability of the prosthesis. Example, 70-year-old B1, fixed with a simple distal femur LCP from the opposite side. The patient could not afford the peri-implant plate, peri-prosthetic plate, and this healed at 6 months. Another example, this can be actually called as type C because it's rather away from the prosthesis, fixed with another, this is the banana plate with cables and screws. Now this is a 70-year-old rheumatoid arthritis. I had fixed her distal femur, bilateral distal femur 10 years ago, and then she presented with this. Now probably a longer plate at that time could have prevented this, but this was a B1 now that I had in front of me. I had to revise the whole thing with a long plate as long as is available, and this healed pretty well at 6 months. And 9 months she is walking with a stick. I'm waiting for the other side to fracture now. Another example, 76-year-old type B1, long LCP, similar circlage wires. Yet another example, similar fracture. Now here I have used the locking attachment plate. Now this is quite a simple and a relatively cheaper option which allows you to, if you look in the lateral view, to have about 8 screws on either side of the stem, and you can even lock those screws in that peri-articular, the locking attachment plate, which can be put over your standard LCP. So this is at 3 months post-op and 9 months walking with a stick. So to conclude, periprosthetic fractures, decision making is purely influenced by the stability of the prosthesis. If the prosthesis is stable, plate the fracture as long plates as possible, spanning the whole bone, length of the bone, along with either medial or anterior strut fibular grafts. They need to be shaped with a burr, and they need to be encompassed within the or along the tube of the femur. If the prosthesis is loose, change the stem and augment along with extramedullary fixation with or without auto or allografts. Thank you.